Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
This activity includes discussion of off-license or unapproved therapies. Please consult your local SMPC or its equivalent for further information.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from Lilly.
Hello, and welcome to this Medscape Oncology program titled Elevating CLL Care, Integrating Evidence, Guidelines, and the Patient Perspective. I'm Dr. Jennifer Wyack, a professor of medicine in the Division of Hematology at The Ohio State University Comprehensive Cancer Center in Columbus, Ohio, and I'm pleased to moderate today's discussion. Joining me today are two distinguished colleagues. Dr. Stefan Silgenbauer, professor and head of the Division of CLL at the Comprehensive Cancer Center Ulm in Germany, and Lorna Warwick, chief executive officer of the Lymphoma Coalition, who will help highlight the patient voice and experience throughout our discussion. Today's program will review current guidelines and emerging clinical data in the treatment of CLL and discuss frameworks of person-centered care. Stefan, could you start us off with an overview of key shifts in CLL management in the era of targeted therapies?
Thank you very much, Jennifer. My pleasure to do this, and it's great to be here with you. So, over the last decade or a little more, we have seen clearly a revolution, I'd say, in therapy of CLL, moving away from chemoimmunotherapy towards targeted agents, mostly oral targeted agents, that have greatly improved the outcome for our patients. These treatments focus on critical elements of CLL biology, the Bruton tyrosine kinase and BCL2 as treatment targets, and has led to the licensing of agents that focus on these disease characteristics. This has really revolutionized treatment not only as a monotherapy, but also in combination, and also allowed for finite duration treatments. So we have a choice for our patients available today and great opportunities that, however, also require decision making. So, in particular, when thinking in the long term, we need to have a strategic view of our patient journey. We need to account for various options that we have available and for how to sequence these agents and how to maximize time on effective therapy while minimizing cumulative toxicities. Health-related quality of life is obviously an essential outcome, and therefore it is great that we have a patient representative here that will help us enlighten us on that view.
Thanks, Stefan. Those are really excellent points. Lorna, could you elaborate on patient reports around the impact of CLL on patients' quality of life?
Of course, it's my pleasure to do so. And again, thanks for including me in this presentation today. So, just to give a little background, the Lymphoma Coalition does a global patient survey on lymphomas and CLL every 2 years. So, the data I'm going to present comes from the 2024 version of that survey, where we had about 2,200 respondents that have had CLL, the patients that were able to respond. And when we look at this data, it's important to note up front that there's a lot of issues that patients are facing. There's, physical issues, psychological issues, barriers to care from a social and economic perspective, as well as issues with their communication with their healthcare professional. When we look at adverse events, of course, 99% of our patients are saying that they experience some kind of adverse event from treatment. The leading issues that patients with CLL report are fatigue, which happens in almost 60% of patients. And what's important to note about fatigue is it's often for patients something that they say is not well managed or they don't feel well supported with. Yet at the same point in time, 38% of patients that have fatigue say that they rate the impact on their quality of life as severe or very severe. When we're looking at the psychological burden, 80% of patients say that they experience some kind of psychosocial distress in the last 6 months due to their CLL. So again, it's a significant issue for patients. I want to focus a little bit more though in the communication related issues that we see with our that our patients are reporting to us. And so even though we have 78% of patients, sorry, saying that they have some kind of psychosocial distress, in fact, 71% feel like their clinicians, if they tell them about these issues, don't follow up on these concerns. And so they are not quite sure how to cope, where to go and get hope for them. Um, uh, Patients generally do understand that clinical trials are their way to access the best, possibly the best treatment for them. Yet, two-thirds of patients say they did not get any information on clinical trials for their doctor, which is concerning. We only see 25% of patients that have been able to access a clinical trial. This does change as their disease progresses, which is understandable because we've had more clinical trials available in a relapse refractory population. So by the time somebody has been relapse refractory at least twice, then we see about 30% of them have access to clinical trial, but there still seems to be some room there. We look again at fatigue, for instance, where we have 78% of patients. That was wrong, so I'm going to start again on that one. And when we look at fatigue, for instance, where we see almost 60% of patients say that they have fatigue, 44% again say they do not get support on fatigue for their physician. So this is just highlighting some gaps that need to be addressed as we move forward. So, really, when we're talking about patient centered care, we want to make sure that the goals of the patient uh, are aligning with the goals of the physician. So, patients are concerned about more than just the efficacy of the treatment. They are concerned about their quality of life. In fact, patients tell us in CLL that they value almost exactly the same the efficacy of the treatment, how long they'll get a remission, with the side effect burden or how they are going to feel during that treatment. And some other things are definitely important to them, how long they stay on our treatment or how the treatment is administered. But more important to them is just generally their quality of life and the amount of remission that they will experience.
So, the central question for today is how can we integrate a patient voice when evaluating guideline directed treatment options with a tailored approach to CLL care? We have standardized clinical guidelines which establish efficacy thresholds and define preferred regimens across different lines of therapy. And we want to have an approach that integrates patient preferences within these established boundaries. So let's start with recalling the prognostic factors that influence our clinical decision making. Stefan, can you start by talking about some of our baseline biomarkers?
Thank you, Jennifer. Sure. So as we alluded to, biology is very important in CLL. We have targeted agents available for this, but also diagnostics are very important. At baseline, and in particular before treatment, it is critical that all CLL patients be assessed for the so-called 17p deletion and for TP53 mutation, which is basically targeting the same gene, which is associated, when aberrant, with very poor prognosis. The other critical biomarker is the IGH3 mutational status that also stratifies patients in good risk when they are mutated and in poor risk when they are unmutated subgroups. We have more biological disease characteristics such as the karyotype or beta 2 microglobulin. However, those do not necessarily in all instances influence our treatment decision to the same extent as the previously mentioned markers do. On the other hand, we have to remind ourselves that also the host, the patient, and their condition is of critical importance. Today, we went away more and more from that classical fit or unfit categorization into specific comorbidities, such as cardiac, cardiovascular, or renal diseases that influence our treatment decision. Now, when it comes to treatment, basically we have available, as briefly introduced in the beginning, BTK inhibitors and BCL2 inhibitors and CD20 antibodies. BTK inhibitors can be given as monotherapy continuously, while BCL2 inhibitors, such as venetoclax, are usually combined either with a CD20 antibody or with a BTK inhibitor. The latter two regimens are time limited, while BTK inhibitor monotherapy is a continuous treatment. Now, when looking at these treatment options and stratifying them with regard to biological disease characteristics, the continuous BTK inhibitor monotherapies such as ibrutinib, acalabrutinib, or zanubrutinib are usually preferred among patients with high-risk genetics such as 17p deletion and or TP53 mutation, where we know that outcome with the time-limited venetoclax-based regimens is somewhat inferior. If we have patients without p53 abnormalities and unmutated IgH3, all options are pretty much equal. Also, the time-limited venetoclax-based regimens offer pretty good long-term disease control, although that may be impacted to some degree by the unmutated IgH3 status. The good risk patients are those with mutated IgH3 and without p53 abnormalities. Among those patients, usually time-limited combination regimens are preferred because they provide a very good disease control, long treatment-free intervals, which is obviously beneficial. Now, all this is still influenced also by patient coexisting conditions. For instance, when there's much cardiac comorbidity, we shy away a little bit from BTK inhibitors who have a risk profile in that direction. On the other hand, with venetoclax-based regimens, renal function is of critical importance, and this is also influencing our treatment decision. So overall, it is a complex scenario. We need to take into account patient characteristics and patient perspectives. And with that, back to you, Jennifer.
So let's talk about the Bruton's tyrosine kinase inhibitors in CLL. As mentioned, BTK inhibitors like ibrutinib, acalabrutinib, and zanubrutinib are given continuously. And this continuous BTK inhibition disrupts signaling pathways that are required for CLL cell survival. The class has evolved over time from the first generation agents like ibrutinib to more selective second generation inhibitors, acalabrutinib and zanubrutinib. The distinctions between the first and second generation inhibitors center on the kinase selectivity, with ibrutinib having less selectivity for BTK and more off target inhibition of other kinases like TAC and EGFR. The second generation inhibitors then are more potent and have higher selectivity for BTK as a target. So looking at some of the data with the second generation inhibitors, we have the phase 3 Elevate TN study, which compared acalabrutinib as a monotherapy and acalabrutinib with obinutuzumab versus chemoimmunotherapy with chlorambucil plus obinutuzumab. We see improvement in progression-free survival and overall survival for the acalabrutinib arms. And at 72 months, progression-free survival is 78% with acalabrutinib with obinutuzumab, 61.5% for acalabrutinib by itself. We also have data with zanubrutinib in the frontline setting from the Sequoia study, which investigated zanubrutinib versus bendamustine plus rituximab, with 5-year progression-free survival of 76% for zanubrutinib and consistent benefit across high-risk subsets. We've seen some head-to-head studies of the covalent BTK inhibitors, both acalabrutinib and zanubrutinib versus ibrutinib. Here's a phase 3 study called Alpine, which compared zanubrutinib versus ibrutinib in relapsed refractory CLL. And we see a significant improvement in progression-free survival for zanubrutinib versus ibrutinib with fewer cardiovascular toxicities. Next, we have the phase 3 Elevate RR study, which was a non-inferiority trial of acalabrutinib versus ibrutinib in patients with relapsed refractory CLL with high-risk features. And we can see here that acalabrutinib is indeed non-inferior to ibrutinib in this setting, and as well did show decrease in cardiovascular complications. So when looking at the second generation inhibitors, there are definitely differences in cardiovascular toxicity rates compared with ibrutinib. And this is really relevant when selecting continuous therapy for patients, both with pre-existing cardiac risks or who might have other other comorbidities or medications that influence these decisions. So both zanubrutinib and acalabrutinib have significantly lower rates of atrial fibrillation compared with ibrutinib, and reduced rates of high-grade hypertension and reduced rates of all-class cardiac events. So, in terms of how we can deal with this potential for cardiac complications with any of the BTK inhibitors, um, it's important to implement a cardiovascular monitoring checklist for all patients receiving a BTK inhibitors so that side effects are routinely evaluated for. And this proactive risk mitigation allows for safe continuation of therapy without having to stop early. So at baseline, we try to identify pre-existing hypertension, arrhythmias, hyperlipidemia, or structural heart disease. And then during the course of therapy, monitoring blood pressure and screening for a new onset atrial fibrillation or other cardiovascular side effects. It's also important to incorporate cardiologists or cardio-oncologists in the care of patients with CLL receiving BTK inhibitors who have cardiovascular complications or who are at high risk for cardiac complications. In addition to the covalent BTK inhibitors, we now also have non-covalent BTK inhibitors, which were initially developed to overcome resistance to the covalent BTK inhibitors. They utilize a reversible binding mechanism that doesn't affect the C4D1 binding site, which is used by all of the covalent BTK inhibitors and can be mutated during the course of therapy with ibrutinib, acalabrutinib, or zanubrutinib. So pirtobrutinib inhibits BTK independently of that site, which can restore pathway control even in the setting of mutations. Now, pirtobrutinib, which is the first in class non covalent BTK inhibitor, has been approved in relapsed CLL, but is being investigated more and more in the upfront setting, given that it has increased selectivity and has been very well tolerated, as well as very potent and effective. So here's some data that we've seen recently emerging with pirtobrutinib in frontline therapy. This is a phase 2 clinical trial from the NHLBI of fixed duration pirtobrutinib and obinutuzumab in previously untreated CLL. So in this study, pirtobrutinib was started initially and then delayed initiation of obinutuzumab at cycle 6, which was then administered as a combination for 6 cycles and then discontinued. Overall response rate after cycle 6 was 78%. And then after the obinutuzumab was added was 100%. Um, the combination was very well tolerated with uncommon cardiac complications. And we'll await further data to understand better the duration of remission following this treatment. We've also seen data from 2 phase 3 studies. One is the Bruin CLL 313 study, which investigated pirtobrutinib versus bendamustine plus rituximab, and the Bruin CLL 314 study, which investigated pirtobrutinib versus ibrutinib. This clinical trial had two-thirds of patients with relapsed refractory CLL and a third of patients with treatment-naive disease. So for this year's EHA meeting, these two studies with all of the treatment-naive patients were pooled to look at both the efficacy outcomes as well as safety. And we can see that the two trials were very consistent. Overall response rate about 93%, 24-month progression-free survival also about 93%, with relatively short follow-up, unfortunately, at this time. Overall survival is very good as well as at this short time period. And the drug was extremely safe with low rates of atrial fibrillation, hypertension, and drug discontinuations. So again, with this study too, with these studies, we'll await longer follow-up to understand durability of pirtobrutinib in the frontline setting. Stefan, can I turn it over to you to take us through the venetoclax-based strategies?
Absolutely. Thank you very much, Jennifer. So, well, in contrast to BTK inhibitor-based therapy, which is a gentle, however long-term continuous treatment, venetoclax-based regimens offer the opportunity for time-limited effective treatments because BCL2 inhibition with venetoclax or similar agents leads to very rapid, very brisk apoptosis of CLL cells, therefore for very quick and deep responses. Venetoclax is combined usually with a CD20 antibody in the front line or relapse setting, or with a BTK inhibitor such as ibrutinib or acalabrutinib, and can then be delivered in fixed duration treatment regimens of 12 months in the front line or 24 months in the relapsed refractory treatment situation. Now, at the recent EHA meeting, we have seen the final analysis of the pivotal trial for the combination of venetoclax plus obinutuzumab from the CLL-14 study. What was presented was the 9-year update of this trial, where we saw a very good progression-free survival with this combination, and actually an overall survival that in median has not been reached after 9 years. So this regimen is leading to long-term disease control, and subsequently other regimens of combination of BTK inhibitors and BCL2 inhibitors were developed. One of those trials was the AMPLIFY study that tested the combination of acalabrutinib plus venetoclax, so an all-oral combination, with or without the addition of obinutuzumab as a 20 antibody. This trial has led to the licensing of this combination and showed that this combination is superior with regard to progression-free survival over chemoimmunotherapy. However, the trial also showed that adding the CD20 antibody leads to increased adverse events, in particular infections, putting a note of caution on this data. The other BTK inhibitor plus BCL2 inhibitor combination that is licensed in Europe is ibrutinib plus venetoclax based on the data of the GLOW study. This has also led to long-term disease control with this all-oral combination, however, highlighted in an elderly patient population some adverse risks with regard to cardiac events. Now, an important study that compared these time-limited treatment options head-to-head and against continuous ibrutinib was the CLL-17 study that was recently published with its 3-year median follow-up time. In this 3-arm trial, continuous ibrutinib against ibrutinib plus venetoclax against venetoclax plus obinutuzumab were tested. The essential result from this trial is that with a median follow-up of 3 years, all these 3 regimens are equally effective. Progression-free survival was almost indistinguishable in the 81% range for all 3 regimens. By biological risk factors, some differences emerged, with in particular venetoclax obinutuzumab being somewhat adversely affected by the 17p deletion and by the unmutated IgHV status, in contrast to the other 2 regimens. Adverse events that we have to pay attention to with these venetoclax-based time-limited regimens are in particular in the beginning of the treatment, neutropenia, and we have to do adequate tumor lysis syndrome management due to the brisk onset of activity of these regimens, and monitor patients and treat prophylactically adequately. When combined with a BTK inhibitor, these regimens obviously also have the BTK inhibitor associated adverse events such as bleeding events, atrial fibrillation, hypertension, and so on that Jennifer, you have alluded to. Now, when summing this up together, continuous BTK inhibitor monotherapy offers predictable, durable disease control. However, it requires indefinite daily adherence to the regimens. The low grade, very low grade, and usually very well tolerable adverse events, however, can occur over prolonged periods of time that may be obviously a burden for patients. The fixed duration regimens, venetoclax based, usually either combined with a BTK inhibitor or with a CD20 antibody, are more intense in the beginning. We need to have more hospital visits or outpatient visits to monitor for tumor lysis syndrome and for the infusion-related reactions with the antibody. However, they offer, so to say, paying off in the longer run, a treatment-free interval for our patients. Now, I'd value input from all speakers on this event regarding weighing these pros and cons against each other. Thank you.
And I'll say, I find this to be a very individual treatment decision. So each patient has things going on in with their life and their lifestyle, as well as, concerns about different side effects and concerns about getting to and from the clinic. I find that this discussion is really different for every single patient you talk to. And outside the very high risk and very low risk patients who you've already talked about, Stefan, for most patients, uh, these therapies are going to be relatively equivalent in terms of efficacy. So it really here is a perfect situation where the patient voice is very important. Lorna, what do you think?
I agree with you completely. 80% of our patients say they want to be involved in shared decision making in some aspect, right? And I should clarify that 60% actually want to be involved in shared decision making, 20% want to make the decision by themselves. And so I think that's really important to note because we actually see that percent increasing over time. Patients are becoming more familiar and wanting to take more control of their health. And really, where the physician has a choice, the patient has a choice in these situations. And the only way you're going to get to the best treatment is asking the patient what's most important to them.
That's great points. Thank you. So let's start talking a little bit about relapse disease now. So we'll talk about treatment sequencing and some of the emerging evidence in relapse CLL. And we have a lot of new advances in relapse CLL that can help us refine our choices in terms of sequencing. Things that we have to think about are prior regimens that have been used, the pattern of relapse, any molecular disease features that were present at baseline and have changed over time, comorbidities and toxicity profiles, as well as patient preferences and goals of therapy. So going back to what Lorna said earlier about patient burdens, we see that there's a spike in the psychological component when relapse occurs. Could you speak a little bit more to that, Lorna?
Yeah, definitely. I think it's important to note here that yes, we see an increase in psychosocial effect as a patient goes through treatment. But what I want to really note is it's about 76% of patients who have been treated once. Let's say they have psychosocial burden, 78% at the first relapse, and then over 80% when we get into more than one relapse. But the things that are impacting patients actually vary quite significantly by that stage of relapse. So it's actually those patients that are relapse refractory one time that are most concerned about the fear of progression or fear of relapse. So they're the most fearful about those things. Where as you progress through the disease, actually patients are more concerned about things like their immunocompromised status or things that are going to really impact their quality of life or their ability to interact with their family. So, again, even if you know your patient well, continue to have those discussions with them because they will change over time about what is impacting them most at any one point in their CLL experience.
Yeah, so it becomes really crucial that we consider all of these factors when discussing the next treatment with our patients. So, just briefly to kind of go through some of these scenarios in terms of relapse CLL. We have some patients who receive the covalent BTK inhibitor as their initial therapy and then are progressing. And they can do so via two manners. One is they progress while taking their BTK inhibitor continuously. And we see that across the covalent BTK inhibitors, mechanisms of resistance are similar. And so we need to do a switch in class. You cannot switch among covalent BTK inhibitors if there's progression on one. And so you would want to switch to either a venetoclax based regimen or a non covalent BTK inhibitor like pirtobrutinib. We'll talk a little bit more about that. The other thing that can happen is actually a patient develops intolerance to a covalent BTK inhibitor, comes off treatment, and then at a later time progresses. And in these cases, a different covalent BTK inhibitor is likely to work very well. And most patients actually do not have a recurrent toxicity if you switch from one of the second generation covalent BTK inhibitors to another. So then after BTK inhibitors, here's some data showing the efficacy of venetoclax. So this was an international study led by the ERIC group that looked at venetoclax-based regimens after prior BTK inhibitor exposure. And you can see here that venetoclax has highly effective, durable salvage responses in these pretreated cohorts. And subsequent line venetoclax is fairly similar to first line venetoclax in terms of efficacy when given in our current manners. We also can switch from the covalent BTK inhibitors to pirtobrutinib. Here's some data from the phase 1/2 Bruin study, which investigated pirtobrutinib after a covalent BTK inhibitor. Median progression-free survival was 19.6 months, and the drug was very well tolerated with, as I mentioned before, pretty limited frequencies of cardiovascular toxicities. Now that we're using more time limited therapies in the frontline setting, we're seeing more and more patients who would relapse after only receiving a BCL2 inhibitor in combination with an antibody or potentially with a BTK inhibitor. We have some limited data on retreatment with venetoclax antibody regimens after progression on an original venetoclax antibody regimens. This appears to be an effective approach, and there's going to be more data coming out with the REVENGE study that'll give us better indication for the use of venetoclax obinutuzumab after frontline venetoclax obinutuzumab. But even in the absence of those data, we can consider venetoclax rechallenge after especially a long prior response, but even relatively short remission durations, I think of 2 years or longer, could be considered. So here's just some pathways that we can think about in treating relapse disease. As mentioned, after a covalent BTK inhibitor, if the BTK inhibitor was discontinued for toxicity, you can think about an alternative covalent BTK inhibitor or venetoclax that was discontinued for progression, venetoclax, or a non-covalent BTK inhibitor. After a venetoclax regimen, if venetoclax was discontinued um, for toxicity or progression, you can go to a covalent BTK inhibitor, or if it was completed with a relatively long remission duration, consider retreatment. For those people who have received both a covalent BTK inhibitor and venetoclax, pirtobrutinib is a good option at this point. Stefan, any additional comments on how you approach these patients with relapsed CLL?
Yeah, thank you, Jennifer, for outlining so excellently the situation that we're getting into with these patients who may have received both very effective BTK inhibitor treatment and also a BCL2 inhibitor based therapy, is the so-called double exposed or even double refractory patient population that we increasingly see, I think, all in our clinics. So, fortunately for such patients, we still have new developments, and one sure is immunotherapy with CAR T cell therapy. Here, we have as a treatment option from the Transcend 004 study, a CAR T cell therapy, which is also licensed by the FDA in the interim in that study, a heavily pretreated patient population um, was enrolled, half of them double exposed. And despite these high risk characteristics, we saw a very good overall response rate and also important durability of these responses in quite a good proportion of patients. Obviously, this is a technically very demanding approach. We see also adverse events, neutropenia, thrombocytopenia, infectious complications, and have to pay attention also to the particular class associated things such as infusion related reactions, cytokine release syndrome, and neurologic events that are prevalent. So it's certainly a demanding approach for patients and for caregivers. On the other hand, we have, as you have alluded to, pirtobrutinib as a non-covalent BTK inhibitor that is truly a different mechanism of action and can be effective post-BTKI. But not only that, it has been shown in the Bruin 321 study that also double refractory patients, so patients exposed and refractory to a covalent BTK inhibitor and a BCL2 inhibitor, can respond to pirtobrutinib and can enjoy, which is important for patients, prolonged treatment free intervals or time to next treatment necessity. And the treatment is, as you alluded to, usually very well tolerated and easy to deliver. So with all these options in mind, I think we arrive at a decision tree where failure of a covalent BTK inhibitor must be clearly classified into either due to adverse events or toxicity, where switching to another BTK inhibitor or pirtobrutinib may be an option, while when due to progression, obviously we cannot switch to another covalent BTK inhibitor, but should go to a venetoclax-based regimen or a non-covalent BTK inhibitor such as pirtobrutinib. After venetoclax treatment failure, obviously the same question arises: is it due to toxicity or due to progression? When it is due to progression on that treatment or shortly after, we usually switch class to a BTK inhibitor. While when there's disease progression after prolonged remissions with venetoclax-based therapy, we may well retreat. So the spectrum of all these options is increasing, and even with more advanced therapies such as CAR T-cell treatment with non-covalent BTK inhibitors such as pirtobrutinib, we in the third line have an additional safety net, I'd say, for our patients, let alone clinical trials that in this relapsed refractory treatment scenario are obviously of key importance. And there we have yet another generation of outstandingly effective classes of agents available. Let me briefly also allude to a trial that was just released a few days ago at the EHA meeting, also adding in these treatment principles together. And this is the Bruin 322 study, a study for relapsed refractory patients with CLL. Median number of prior lines was 2, and the majority of these patients had prior therapy with a BTK inhibitor. Here, in this trial, the relapsed refractory standard of venetoclax rituximab was challenged by the triplet combination of venetoclax rituximab with the addition of pirtobrutinib. And this trial, fortunately so, I'd say, was very positive. Primary endpoint progression-free survival was met with superiority of this pirtobrutinib plus venetoclax plus rituximab regimen for these patients with a very tolerable adverse event profile, so that possibly here we may have a new standard once licensed in the future in the relapsed refractory setting. However, as all these options are increasing, as we have alluded to, patient involvement, caregiver involvement is becoming more and more important. Some patients are sheerly overwhelmed by all these options and ask questions, well, doctor, what should I do? And Mona, I think at that point, really shared decision making is at the heart of our best care for patients, isn't it? So maybe a few points from your side on that.
Yeah, definitely. I do think that the information is complex. I definitely agree with you on that. I think maybe the way that we frame the conversations with our patients becomes more important. And so you're making sure you understand the goals of their care and what the impact on their quality of life is that they're willing to tolerate at this phase, more than explaining, would you like treatment A versus treatment B, because those decisions do become a little bit more difficult. Now, you will definitely run into patients that have a very clear opinion on which treatment they would like to get. But I would like to point out the more times a patient relapses, the less likely they are to say that they are satisfied with their participation in shared decision making. So they find it more difficult to do. They also are less likely to say that they think their doctor understands the impact of their disease on their quality of life. And so, again, it reinforces that need to have those constant discussions with your patient to make sure we're balancing toxicities or the impact of the treatment itself with what it is that the patient wants to see, right? And so, patients, as they relapse more, are actually willing to tolerate more side effects often because they know that that's they need to do in order to get a longer survival. So basically, there is a lot of room to have those discussions. I know there's a study that's shown here. This was actually a study that happened in the US and was focused on patients that were getting their very first treatment. So a little bit different than we had just been discussing. But what it does show is the difference between a doctor's perspective on what they think is important and what a patient thinks is important. And so you'll see here there are some significant differences in how long patients will be alive compared to how a doctor rates that versus how a patient rates, for instance. And again, how severe some physicians may rate certain side effects and what patients are willing to tolerate. So it does reinforce the need for discussions. I will say as well, because this is a US study, for everyone to be aware, there are differences between US patients, we noticed, and European patients when we did a cross analysis of our data. And for instance, for some reason, patients in the US are far more concerned about their immunocompromised status than we see in Europe. It doesn't mean patients in Europe aren't concerned, but they have other concerns that are equally important to them. And so, even when you're reviewing literature, it comes down to at the end of the day is having a good conversation with your patients so that you actually do understand what is most important to them. From here, we're going to move into this is me, right? Yes. Okay. Um, so from here, we are going to move into um, some. Sorry, I'll start again. I just missed my slide. Okay. So from here, we're going to move into a couple of scenarios. We'll talk about some patient situations and get some feedback from both of our physicians online here, talking about how we might best approach these. So in our first scenario, we have a 62-year-old treatment naive woman who requires initiation of her frontline therapy. She does have a medical history of some AFib, and she's quite anxious about the cardiovascular issues that might arise with treatment. Uh, and so it does, of course, need an explicit evaluation of the drug safety profiles in this particular instance, both from a medical perspective and to ease her anxiety. So, Dr. Woyach, if you could give your opinion here, please.
Absolutely. So we don't know anything about this patient's risk status, but we'll assume that either a continuous covalent BTK inhibitor or a fixed duration regimen with either venetoclax obinutuzumab or venetoclax acalabrutinib is appropriate here. And of course, the patient's known atrial fibrillation influences our suggestion. I'm sorry. The patient's known atrial fibrillation influences our selection of treatments. We would, of course, want to avoid ibrutinib due to the higher rate of cardiovascular toxicities. Even with controlled atrial fibrillation, zanubrutinib or acalabrutinib could be appropriate choices with post cardiac monitoring. And then the pre existing risk could justify choosing venetoclax with obinutuzumab, and then as well, venetoclax acalabrutinib would still have some BTK potential toxicity, but a shorter duration of treatment. So when we present these trade-offs, we try to leverage discrete choice data to address the patient's concerns. So in this case, given the patient's anxiety about the cardiovascular risk, we may think about using something fixed duration, either venetoclax or obinutuzumab to completely eliminate that cardiac risk, or venetoclax acalabrutinib to have that risk, but just for a shorter period of time. However, if the patient does prioritize doing something that is more easy and doesn't require a lot of visits to the clinic, you still could consider a selective BTK inhibitor. Um, Stefan, any tips on how you might approach this conversation with the patient?
Yeah, absolutely, Jennifer. Thank you. Absolutely agree with you. Obviously, we have these great advances, for instance, also with pirtobrutinib, that may be available in the frontline setting. Um, we have seen in a randomized trial that the adverse event of atrial fibrillation was very rare, and it was actually of the same frequency as with chemoimmunotherapy. So it may well be that we are down to a rate that is corresponding to background noise. So tolerability is improving with these agents. I'd agree this involves a deep discussion with the patient, continuous gentle therapy, possibly with a second or third generation BTK inhibitor, versus a venetoclax-based approach that is a bit more intense in the beginning for the patient, but then offers treatment-free period. So, Lorna, back to you again. Again, it comes all down to informed decision making in partnering between doctors and patients, isn't it?
Definitely. And I'm glad that you both pointed that out. This is completely a situation where we do need more information from the patient about what is important to them over and above the fact that they have AFib. So there are choices now, and of course, our patients should be getting that choice. If we move into our patient scenario number 2, where we're relapsing after a covalent BTKI and BCL2, you'll see this as a 72-year-old man who has relapsed CLL. and needs his second line therapy. He has received first line a covalent BTK inhibitor and did get a complete response, but experienced some significant arthralgia and therefore transitioned to a venetoclax obinutuzumab regimen. He's very active, which is great to see, and he values his physical independence, which we appreciate because, of course, that often allows patients to continue to live independently when they are active themselves and able to maintain some degree of physical activity. But his current goals prioritize, of course, long term disease control without compromising that daily functional status. So, to you, Dr. Stilgenbauer, what would you recommend for this patient?
Yeah, thank you, Lorna. Here we have this classical example of a double exposed patient with, some issues during prior therapy. From a very, let's say, formal basis, in the United States, we have available for such patients CAR T cell therapy as a licensed option, which is not available in Europe, and non-covalent BTK inhibitor pirtobrutinib, with both of them good clinical trial data. Despite the patient's age of 72 years, if they are still really fit and active, CAR T cell therapy, despite being a very invasive procedure, it could be an option. Again, making it so important that shared decision making is applied here. CAR T cell treatment obviously is more invasive, is associated with, or may be associated with, deep and durable responses, however, also with potentially life threatening adverse events. So, clearly, good also network, caregiver network is important. On the other hand, pirtobrutinib is a more gentle treatment, is a continuous therapy that can be easily delivered in an outpatient setting. However, it needs to be taken continuously and also may be associated with more low grade adverse events that may continue to accumulate over time. So, Jennifer, I'd be curious to hear your thoughts, how you usually tackle such decisions.
Yeah, I mean, I agree with everything that you said. I think for some people are more interested in an intensive option that might give them a very long remission duration, in which case I would consider CAR T cells. Many though want something that fits into their current lifestyle, and pirtobrutinib is a really attractive option for that. The only other thing I would consider too is if the patient was willing, you could consider rechallenging with an alternative covalent BTK inhibitor. So if they have been on acalabrutinib, triazanibrutinib, or vice versa, they may have a similar toxicity again, although sometimes these toxicities don't occur again, and we can get additional therapy from this kind of first line regimen. So now we're very near to the end of our program, and I'd like to ask Lorna to highlight the most important components of person centered care in an evidence based practice.
Really, it comes down to having good, honest discussions with your patients. Transparency in the situation that they're in is important. Honesty. Don't be scared of the bad news, even though I know sometimes that's hard to communicate. But letting patients fully understand or giving them the good information so that they can participate in their care, checking their understanding, but remembering as well that you don't have to be the only source of information and support, making sure you're referring patients on or signposting them to other avenues where they can, hear from peers, people that have been there, done that, patient organizations, other places that they can get some support to help them through what is going to be a very long experience, usually with CLL.
Thank you very much. Stefan, any concluding comments from you?
Well, yeah, thank you, both of you. It was an inspiring discussion. I think highlighting to me again that we're living in great times for our patients with CLL. We have many options. We can offer really well tolerated treatments with great efficacy. Nevertheless, there are multi dimensions to that, ups and downs for all treatment options, clearly highlighting how individualized treatment is. We're living really in an era of personalized medicine that is very important to base our treatment decisions on informed decision making together with the patient. And that will, in my opinion, lead to best outcomes for our patients.
Yeah, thank you. And I'll just echo, I think this is such an exciting time in CLL. And as we get more and more of these options, it's becoming increasingly important that we discuss all the options with the patients and really understand what are their priorities so that we can make sure that we're all making the correct decisions. So with that, I'd really like to thank you, Stefan and Lorna, for joining me today in this program. Thank you to the audience for viewing this, and have a great day.